Very good morning to everybody. Thank you, madam, for those warm words. Can I go to the first slide, please? So, recurrent pregnancy loss is a very upsetting condition which comes to all of us who are practicing. So, it could be would be mother with first pregnancy loss, or she has had abortion once and again she's coming with a pregnancy and a spotting, or it could be 2 and more abortions. So, just let us go through the basics. Next slide. So, we are just going to go with the following contents. Next. So, it is defined as 2 or more failed pregnancy, especially when the cause is unknown. Each pregnancy loss merits careful review to determine whether specific evaluation may be appropriate. It is one of the most complex and challenging scenarios in reproductive medicine, and it is frustrating for the patients, their families, and the treating physicians. Next. So, the primary RPL is less than 24 weeks of gestation, and secondary RPL is defined as an episode of RPL after 1 or more previous pregnancies progressing beyond 24 weeks of gestation. Next. And we need to understand that it is most often unrecognized. So, each menstrual cycle actually leads conception of up to 30% at time. So, we have seen various cases of the chemical pregnancy where the patient says that yes, I had missed the periods by few days, and then I had started to spot, and then I got my regular cycles. It is a routine history from many of our patients, and we always make sure that it is only an pregnancy which is getting aborted, and there is always the ectopic pregnancy which should be in the back of the mind before we take the appropriate action. Next. So, the global and the Indian incidence of the recurrent pregnancy loss, we need to understand that it affects roughly around 2 to 5% of the couple, and especially in Indian women, when compared to the Western women, the spontaneous miscarriage rate is around 10 to 32%. Next. And the prevalence of this recurrent spontaneous pregnancy loss among the Indian women is at the both extremes of ages. So, here you see that more than 33 years it is around 15%, and less than 22 years it is around 10%. So, again this has to be, and more women are getting married late, and and even if they are married young, they are postponing their first pregnancy for the first few years. So, all these are making these cases more difficult for us to manage. Next slide. So, here though we are able to give a lot of reasons here, more than 40 to 50% still we are not able to identify the causes. So, here we have the genetic factors which is around 5%, we have the anatomical factors which is around 15%, 20% now we have identified that autoimmune is the cause, and we have 17 to 20% which is the endocrine disorders. Next slide. And of course, we all know that the inadequate secretion of the progestogens in the early pregnancy has been linked to the etiology of high-risk pregnancy, and this is the main motto of the management also. So, most of us do prescribe plenty of progestogens just for this very reason. Next slide. So, we understand that it is crucial throughout the pregnancy. It induces the endometrial changes into the secretory phase, preparing the fertilized egg for the implantation. It also regulates the balance of cytokines and influences the activity of natural killer cells, and also suppresses the uterine contraction by enhancing the nitric oxide protection in the lining of the uterus. So, all this is necessary for the implantation and the continuation of the pregnancy throughout the 9 months. Next slide, please. And what are the suggested diagnostic evaluation? So, we have the genetic evaluation, which is the parental karyotyping. We have the anatomic in the form of HSG or office hysteroscopy or 3D ultrasound, which is now actually we are starting to use this 3D ultrasound in a big way in the management of the RPL cases. Again, in endocrine, TSH is the most common cause, and it is very easily correctable also. So identifying these endocrine disorders and trying to manage them really helps these patients in the subsequent pregnancy. Of course, infection, again, though it's a 2 to 5%, it is very important to evaluate and manage. So all these things, if identified, can be managed, and the patient is going to be very happy subsequently. And of course, autoimmune disorders and non-antiphospholipid antibody syndrome. So all these are there in almost around 20% of the patients. So meticulously, we have to investigate and we have to take these cases forward. Next. So this is the proposed evaluation for the recurrent pregnancy loss. So let us see what is the updated strategy for these cases. Next. Next. So the main thing in evaluation is the history. So here the patient is going to come to you with a lot of heartbreaks, with plenty of tears and very stressed out family members. And so you have to, first of all, connect with them and maybe gain their confidence and then start taking a very, very detailed history. This is what is lacking in many of the cases. So when she comes to you with the first abortion itself, then probably, you see, these patients, they don't come to the same doctor for every abortion. So they go to Dr. X and then the XY and then probably to me after 2 or more abortions. So after each and every abortions, her stress is going to really hit the roof. So again, when was the abortion, how many weeks of gestation, what was the basic thing, everything has to be the age of the patient, the weight of the patient, previous histories, family histories, personal histories, any chronic diseases, was she on any drugs. So all these histories should be taken very detailedly, and of course a physical examination. So we'll have to do a general examination of the patient, and if possible, if she's coming to you without a pregnancy, for a pre-pregnancy evaluation, better to do a gynec checkup also to make sure that you're not missing out in the local examination or in your bivaginal examination. And then we'll have to appropriately investigate the patient case by case. Next slide. So this is the rough guidelines, what they are saying. So here the Royal College, the ASRM and ESHRI have all given various strategies, but the recent proposed 2020 strategy is that this has been given in the guidelines. So a patient comes to you with a history of frequent abortions. Parental karyotyping is not recommended unless the POC reveals unbalanced translocation. So we are doing plenty of parental karyotypings, but now they are saying that only when the product has some problems, then probably you will have to recommend it. And then about the cytogenetic analysis of the POC, again it is recommended for the second and the subsequent pregnancy loss. And again, uterine anatomy evaluation, you will have to do it with an advanced ultrasound, and of course antiphospholipid antibodies, thyroid function, prolactin, HbA1c, all these are basically recommended for all the patients. And then when comparing to the special tests like hereditary thrombophilia, sperm DNA fragmentation, PCOS, and insulin resistance, luteal insufficiency, all this, ovarian reserve testing, vitamin D deficiency, all these are only recommended if if there are certain issues in the history taking, and always and recommended only for some of these investigations are only recommended for the explanatory purpose. And then again, vitamin D now has been identified as a major factor in the management of RPL. So a lot of studies are going on and a lot of papers are coming in support of recommending vitamin D for these patients. Next slide. So the initial consideration is that the compassionate care and clear information on the causes and the treatments of RPL. So the healthcare providers, we should support, understand and acknowledge the pregnancy losses as they are significant life events for the patient. So the tender loving care, the term tender loving care is very much in vogue today, and we are supposed to handle these people with the tender loving care. And of course, as you all know, that we have to give lot of importance in lifestyle modifications and again counseling. So lifestyle modification is the main problem which is coming in today's thing, because they are all mostly sedentary lifestyle. They have habits like alcohol, smoking, and they are having a very stressful life. And of course, even the matrimony between the husband and the wife really is has to be discussed in detail. So all these have to be discussed. Find out what could have been the probable reason. Why was she stressed? Why has she gained weight? Is she having any hormonal problems for the weight gain? Genuine problem which could be corrected, or she has to tell her to reduce at least 5 to 10% of her weight, initial weight. Goes in a big way to improve the reproductive potential. Next slide. So now we have the modified evaluation and the treatment algorithm. So all known prevalent and potentially treatable abnormalities in the first trimester loss RPL cases, whether anatomical or immunological or endocrine, are to be addressed regardless of the POC cytogenetic analysis results. So the modified evaluation omits the parallel karyotypic analysis from the initial workup, replacing with the systemic CMA chromosomal microarray evaluation of the miscarriage tissue. So the cause behind RPL is that the 40% of the cases as recognized by these various organizations includes uterine abnormalities, APS, thyroid and prolactin and endocrinal disorders, and all these, if identified, can be prevented, and we will be able to give successful pregnancy in the subsequent thing. Next slide. And so again, the updated algorithm recommends that the uterine cavity should be evaluated for all RPL cases. So they prefer, everybody says that the ultrasound, the routine 2D ultrasound should be improvised to 3D ultrasound, and 3D ultrasound is almost equivalent to a hysteroscopy if done by efficient hands. So just doing a proper ultrasound of the uterus will tell us about the shape of the uterus, the cavity of the uterus, and is there any polyps, or so many other intricate things within the uterine cavity which could be the cause of the RPL can be recognized. And of course the ovarian pathology, the antral follicle, so many things. If it's a good ultrasound, we can see so many things through the ultrasound. So, and of course after this, there is, we are also trying to, the next step is that sonohistography or hysteroscopy or hysterosalpingography also, or other methods to evaluate the uterine cavity. Next slide. And of course, next is the APS screening. So it is again recommends the screening of APS as a potentially treatable and prevalent diagnosis in RPL women. All three societies are recommending APS using lupus anticoagulant, IgG and IgM. So the general consensus recommends that the low dose aspirin beginning before conception and a prophylactic dose of heparin, starting with a positive pregnancy test and continuing to delivery for these patients who are tested positive, really helps in taking the pregnancy forward. Next slide. Again, the evaluation of thyroid and prolactin abnormalities. We have when the thyroid TSH level is above 2.5, especially in combination with the positive thyroid peroxidase antibodies, we initiate the initiation of low dose levothyroxine is advised. And also they also have published recommendations for hormonal testing, including TSH, TPO antibodies, prolactin, HbA1c, diabetes, insulin resistance and ovarian reserve. So all these are again, if diagnosed and if taken care of medically or with whatever means, the patient is going to have an improved outcome in the subsequent pregnancy. Next slide. Yes, vitamin D deficiency has been associated with severe obstetric complications, including miscarriage. So ESHRE is actually issuing a recommendation to consider vitamin D supplementation for all cases in part of preconceptional counseling. So judicious vitamin D dosage based on follow-up investigation can be beneficial for the overall health in patients with RPL. The latest in RPL is vitamin D. Next slide. Okay, so now suppose she comes after a second miscarriage. So you will have to, apart from the routine work, we will have to screen for weight extremes, alcohols, smokings, cavities, screening for APS, endocrine testing, etc. Then once you have found out the cause, we have to treat the cause. So manage abnormalities and consider prophylactic vitamin D and provide psychological support. So once she has had a first miscarriage, we are going to have the basic investigation, and next, once she has had 2 abortions, then we have to do all the tests before we allow her to plan for the 3rd pregnancy. And we should be prepared for any complications which might come during the period. Next slide. So she is coming to you with an abortion, and you have now got the product of conception. So this is a simple algorithm. So if the POC is aneuploid, no further testing. But if the POC is euploid, if there is any abnormal cavity or endocrine etiology or APS, you please address the problem and then go in for expected management. But if there is no identified etiology so far, then these cases will become the unexplained cases. So then consider hereditary thrombophilia testing, sperm DNA fragmentation testing, parental karyotyping, luteal phase deficiency testing, chronic endometritis testing. So all this, hysteroscopy of the uterus also is necessary. So try to identify the specific problems and then start treating them accordingly. And unbalanced translocation or inversion, again parental karyotyping, genetic counseling, and consider PGT with expectant management. Next slide. So after the 3rd miscarriage, if she's coming to you for the first time with no previous test done, then investigate her completely and manage according to the above mentioned algorithm. If the above algorithm has been already followed in the previous miscarriage, repeat the POC, chromosomal testing, and complete the full workup if not already done. So if all possible known etiologies have been addressed and POC aneuploidy is repetitive, consider expectant management with PGT management. So you can take it to the next level. You can do further chromosomal testing of the, these people will need a higher level of management like your IVF and PGTA testing, and then maybe transferring the healthy embryo inside and stuffs like that. So basically the patient has to be referred to a facility where they have all these facilities. So it is always better to accept that I can do this much at my level. And so now I think I need to send her elsewhere so that she will end up with a healthy baby. Next slide. So we all know that we are using progesterones and deficiencies. So all of us are voracious writers of progesterones because there are so many scientific things which are actually in support of progesterones. So the progesterone in pregnancy has been established as an adequate immune environment at the early stage. So it prepares the endometrium, it makes sure that the pregnancy is getting continued by taking care of the cytokine productions, and also the deficiency has been associated with insufficient endometrial maturation and inadequate regulation of the inflammatory cytokines. So all these can result in abortions or in IUGR or in so many other complications for which we will have to be carefully monitoring. So the support with progesterone may help to establish a sufficient immune response in the early pregnancy and preventing the miscarriage. Next. So to conclude, RPL is a significant life event for couple and especially for the female. So where most of the RPLs are unexplained, the chances of identifying a treatable cause can be enhanced with a strategic evaluation based on the guidelines. The approach should include the previous diagnostic and the investigative analysis to avoid undue expenses and effort. Where adopting excellent advanced techniques of evaluation and management for providing the care with an edge, one must not forget the eminence of basic counseling, the tender love and care, and adequate nutritional support. Thank you. Next slide.